Hello everyone and welcome to this week's VJOncology podcast, focusing on exciting lung cancer highlights from the 2026 ASCO annual meeting. In this episode, our experts cover key trials including LIBRETTO-432, CROWN and TRITON, as well as studies evaluating low-dose pembrolizumab and thoracic radiotherapy. First off, Alessandro di Federico from the Memorial Sloan Kettering Cancer Centre discusses his highlights in lung cancer from the meeting, exploring the LIBRETTO-432 trial of adjuvant selpercatinib in RET fusion-positive non-small cell lung cancer, 2 trials of KRAS G12C inhibitors, and the 7-year update from the CROWN trial of lorlatinib in ALK-positive non-small cell lung cancer.
There are 4 abstracts that I will talk about there. The first one is a phase 3 study, the LIBRETTO-432, which tested selpercatinib, a RET inhibitor, for patients with non-small cell lung cancer resected stage 1B to 3A. Selpercatinib was given at the same dosage as in a metastatic setting, so 160 milligrams twice a day for up to 3 years. These results were somewhat expected because they're compared with placebo in the adjuvant setting, and we've seen some benefit, huge benefit actually, with other drugs. I'm thinking about alectinib for ALK fusion-positive tumors or osimertinib for EGFR mutant non-small cell lung cancer. So the median EFS, which was the primary endpoint of the study, was not reached with a median follow-up of 24 months for selpercatinib. So the median follow-up was actually shorter than the planned duration of selpercatinib with a hazard ratio of 0.17. So we'll see whether these curves will tend to reconverge after the duration of the planned duration of the drug after 3 years, as we've seen with osimertinib in the ADAURA trial. So, and we will see if there's room for extending the duration of therapy after 3 years, or maybe indefinitely for this patient. But these results are very important, and I hope I will see the same study for other oncogene-addicted populations such as HER2, KRAS, ROS1, etc. The other 2 trials testing KRAS G12C inhibitors in patients with KRAS G12C mutant non-small cell lung cancer in the first-line setting. One was the Crescendo 170 trial, which tests divarasib plus pembrolizumab in 2 cohorts, one cohort with PD-L1 positive and one cohort with PD-L1 negative tumors. The results were quite impressive in terms of efficacy, with an objective response rate of 70% and a median progression-free survival of 19 months. So very impressive. It was objective response rate actually was 73% in the PD-L1 positive and 70% in PD-L1 negative. So very similar among the 2. And the PFS of 19 months was in the PD-L1 positive population, where it was not reported for the PD-L1 negative population, but still very, very promising efficacy. The concern here is in terms of safety with this combining the KRAS G12C inhibitor with immunotherapy. We've seen previous trials showing concerning safety profile. And in this trial, there were 65% of grade 3 or 4 treatment-related adverse events, mostly diarrhea of any grade in 75% of patients, grade 3 or 4 in 60% of them, and also other gastrointestinal toxicities such as nausea or vomiting. And also, we've seen roughly 20% of cases with elevated liver functional tests, AST or ALT, increase of grade 3 or 4. So this is mostly the limitation of applying this drug to the general population, but we'll see in larger cohorts if this is confirmed. And then the other trial is testing alisrasib in patients with KRAS G12C mutant non-small cell lung cancer. Alisrasib is another specific KRAS G12C inhibitor. And we've seen some good results with combining alisrasib with pembrolizumab or in monotherapy. In monotherapy, the objective response rate was 78%, while combining this drug with pembrolizumab was up to 81%, but the response rate was up to 95% in those with high PD-L1 expression, meaning at PD-L1 TPS of at least 50%. Here, the toxicity profile, of course, is comparing to different trials indirectly, so it should be taken with caution. But the toxicity profiles looks a little bit better. The rates of grade 3 or greater adverse events were 30% with this combination, and we've seen 6 to 8% of AC or LT increase of grade 3 or 4. So maybe this combination is a little bit safer, a bit tolerable, but we'll see with larger sample size if that's confirmed. The last but not least trial is the CROWN trial. It's in the 7-year update of this trial. This is a trial comparing lorlatinib to crizotinib as first-line treatment for patients with advanced non-small cell lung cancer harboring ALK fusions. This is, I think, the drug that is giving us, in non-small cell lung cancer at least, the best results so far, as the progression-free survival is still not reached after 7 years, with an hazard ratio of 0.19 versus 9 months of median PFS with crizotinib. The risk of having a progression in patients who did not have a progression after 2 years was 79% risk of not having progression, so up to 7 years. So it's very good results and very reassuring for patients with who receive this drug up to 2 years without progression. So incredible results, and yes, this is the best we have so far in non-small cell lung cancer.
Dr. De Federico also presents findings from the Phase 2b TRITON trial, evaluating first-line durvalumab with tremelimumab plus chemotherapy versus pembrolizumab with chemotherapy in non-small cell lung cancer patients with KRAS, STK11 or KEAP1 mutations.
The TRITON trial was a Phase 2b study presented here at ASCO by Dr. Skoulidis, and it compared first-line durvalumab plus radiotherapy plus chemotherapy versus pembrolizumab plus chemotherapy for patients with non-small cell lung cancer having KRAS, STK11 or KEAP1 mutations. And this is a population that is relevant to study because there were some previous studies by Dr. Skoulidis and also our collaborator Dana-Farber MSK that show that patients with STK11 or KEAP1 mutation, they can have poor prognosis with immunotherapies, and even some patients with KRAS mutation, particularly due to the mutant allele, can have poor outcomes with immunotherapy. So this is for sure a population that needs better options. And the dual immune checkpoint blockade with durvalumab and tremelimumab, so PD-L1 and a CTLA-4 inhibitor can provide, maybe can add some benefit. And this trial showed that I think the most important finding is that there was a numerically higher objective response rate with the dual immune checkpoint inhibition, but most important finding, I think, was that 100% of patients, so all the patients who responded, were still responding after 6 months with durvalumab plus tremelimumab plus chemotherapy versus 58% of patients in the pembrolizumab plus chemotherapy arm. And I found this result interesting because there was a meta-analysis published last year by our group and also Dr. Skoulidis as a collaborator. This was a meta-analysis of 6 randomized clinical trials, and we compared dual versus single immune checkpoint blockade in non-small cell lung cancer. And what we show is that patients with STK11 mutation and those who were PD-L1 negative derived improved overall survival. But the effect, especially in the PD-L1 negative population, was long-term. So the curves were mostly overlapping for the first years since randomization, and then they were separated in favoring the dual immune checkpoint blockade arm, with nearly doubled overall survival rates at 5 years. So we've seen this kind of long-term benefit, and the meta-analysis, this seems to be partly confirmed. The sample set in the TRITON trial is not so big. There were 84 patients enrolled at that cutoff, but still it is confirming what we found previously. And Dr. Scurry, is interesting. They have published a paper in Nature in 2024 providing some mechanistic explanations about the role of dual immune checkpoint inhibitors in this tumor harboring STK11 or KEAP1 mutation. It seems that dual immune checkpoint blockade can improve the activation of CD4 plus T cells and reprogramming the myeloid compartment towards a tumoricidal phenotype. So something very interesting, the PFS was still blinded at the cutoff, so it was not presented in ASCO, but I'm eager to see what are these results also in terms of PFS.
Next, Erika Ruiz-Garcia of the Instituto Nacional de Cancerologia discusses the Phase 2 FLAME trial, evaluating osimertinib plus chemotherapy versus osimertinib monotherapy in non-small cell lung cancer with circulating ctDNA EGFR mutations.
These kind of trials are very interesting because we try to find out how new tools like the ctDNA can help to escalate treatments for those patients that persist with mutations besides they got a specific treatment for that. So I think that idea is great. The study has some methodological issues, and that's why we cannot consider the results as a change in practice. Also, we find out that the persistence of those kind of mutations might be related with tumor evolution because of the treatment pressure. But besides that, I think that the panel that was performed to know what kind of persistence was present was not so big enough. So a suggestion is that it is need to have a more comprehensive test trying to know what's going on with this kind of pressure that the treatment does into the EGFR mutations.
Following on, we next spoke with Nandini Menon of the Tate Memorial Centre, who shares insights from a Phase 3 study of low-dose pembrolizumab compared to chemotherapy in patients with non-small cell lung cancer without driver mutations.
So the Phase 3 study that we had was looking at patients with non-small cell lung cancer who did not have driver mutations or the actionable targetable mutation. So in those patients, we used low dose of pembrolizumab, which is 50 milligrams as compared to the 200 milligrams, which is a recommended FDA-approved dose. And we compared it to chemotherapy alone. And just to must remember that this population is that which would not get any kind of immune checkpoint inhibitors. It's not those who could access the standard dose of pembrolizumab. So the main findings was that the primary endpoint of the study that we looked at was overall survival. And in this, the addition of the low-dose pembrolizumab to chemotherapy improved the overall survival. So patients lived longer. The median overall survival was 10.47 with chemotherapy alone. And with the addition of the immunotherapy, it went up to 13.4 months or 13 and a half months. And it was significant, and there was a benefit, around 12.9% absolute benefit at 1 year by adding the low-dose immunotherapy to chemotherapy rather than giving just chemotherapy alone. So this seems to be a significant improvement, especially for those who would not have got any kind of immunotherapy.
Dr. Menon also discusses alternatives to pembrolizumab and the challenges of integrating immunotherapy into the treatment regimen in India.
So I think the standard dose of pembrolizumab has been around, and it is what is approved. The competitors that are there would be nivolumab and ipilimumab with chemotherapy that is there. But there are a lot of new molecules coming from other parts of the world, and some of them have got an FDA approval. Not all have got for non-small cell lung cancer. So a lot of the Western guidelines don't incorporate them. For us in India especially, because immunotherapy is not a part of, it's not covered by government insurance. It's a largely out-of-pocket expenditure. So the integrating all these immune checkpoints into the treatment algorithm, although it is pembrolizumab is something that is now standard in the treatment paradigm. It's not a new or a novel drug. But even then, for us to deliver it to patients whom we want to deliver it is a challenge. So the whole goal of the study was to get something that was more, accessible to our patients. We hope that by reducing the cost to around 1/6 to 1/7 of what it would cost in India to give full dose pembrolizumab, we probably could open this to the government bodies and other funding agencies and insurance in India and make it, their minds will be open to accept it. And included as part of standard coverage. The newer molecules, definitely, we talk about the Chinese immune checkpoint inhibitors. About 4 of them or 3 of them have come into the market in the past 1 year. Their costs are much lower than pembrolizumab, of course, but not all of them have been FDA approved. Not all of them have been approved by our Indian CDSCO for non-small cell lung cancer yet. So though they are economical, we are kind of extrapolating some of the data, but I think they also will definitely get incorporated into the treatment paradigm because eventually they will get the approvals and they are more affordable. So again, there will be a large space that there will be many competitors. So the monopoly will slowly go down. So probably the cost of therapy will start coming down when this happens.
Finally, Bjorn Henning Gronberg of the Norwegian University of Science and Technology presents findings from a phase 3 trial evaluating thoracic radiotherapy with chemoimmunotherapy in extensive stage small cell lung cancer.
Main finding were that there was no survival benefit of adding thoracic radiotherapy to chemoimmunotherapy in extensive stage small cell lung cancer. In addition, there were more adverse events, and most importantly, there were more treatment-related deaths in the experimental group. We have done some exploratory subgroup analysis, and we haven't been able to identify any subgroups that appear to benefit from the addition of thoracic radiotherapy. Since most other trials administer the radiotherapy after the chemoimmunotherapy, we also looked at patients who complete all 4 planned chemoimmunotherapy courses, and also there was no signs of effect. And the best prognosis group, the patients without brain or liver mets, also there, no signal of an effect. So I think this trial tells us that adding thoracic radiotherapy should not be done outside of clinical trials, with, of course, the exception of patients who have symptoms from tumor compression of the central structures. They should probably receive palliative radiotherapy as before.
Thank you to our speakers and to you for listening to this podcast. If you enjoyed this episode, please leave a review and subscribe on your favourite podcast app, including Apple, Podbean and Spotify, so we can continue to deliver our expert-led content directly to you. Follow us on X at VJOncology to join in the conversation and visit VJOncology.com for the latest updates in the field.